we were treating acute myeloid leukemia with 7 and 3 in 1977. We are doing the same in 2018. The reason I'm asking this question is basically treatment for most common types of cancers has not changed in the last 50 years. How do you see the way forward to make this more, to accelerate the progress?
My own bias is, I think when we classify these diseases like AML, it's a phenotypic classification based on morphology or markers and things like that. So I think, in my judgment anyway, any disease, once you do that, I think it'll be very difficult to really get deeper into exactly how to treat them because they're going to be so heterogeneous from patient to patient. So my hope was that by really understanding the molecular basis or the pathways that are disordered, how they are disordered in different patients with the same so-called phenotypic disease, then we'll be able to make progress. But if we all clump them based on diagnostic criteria and use the same protocols, obviously some will respond and some won't respond, and depending on how you define the success of the trial, then there are going to be issues. So my own personal bias is that we really have to base these treatments on understanding pathways that lead to the same phenotype. At least that's my strong bias, that this is not a single disease, although classically it is one form of leukemia that is myeloid, acute myeloid leukemia. So that's my bias anyway, yes.
Question number 2. There are 3.5 million papers published on cancer. 135,000 papers were published in 2017 alone. There's a staggering disconnect between great scientific insights and their translation into improved therapies. What are we doing wrong here?
Again, this is all my personal bias views. I want to be very explicit about it. When you quote those numbers, like the number of papers, I would take a very hard look about how critically these tests were studied and what is the message of these things. And my own personal bias is a lot of people, again, in my own field of erythropoiesis, there's a lot of work being done with cell lines, established cell lines. And I have a serious question about the validity of experiments and outcomes of results using solely based on cell lines. My strong bias, which we try to do in our lab anyway, is try to validate. You can do it with cell lines because there's a starting point to get deep understanding of the pathways and all. But unless you go back to primary cells and validate critically what the outcomes of these things, I have a strong feeling a lot of these results are not going to hold out when you actually apply it to normal physiology and pathology. So that's where I think, even though there are 300,000 or whatever papers were published, in my judgment, probably 10 or 20 are really good, and the rest of them I'm not convinced. That's my bias, okay?
Good answer. The fact that children respond to the same treatment better than adults seems to suggest that cancer biology is different, but also that the host is different. Now, since most cancer incidence increases with age, this seems to suggest that even having therapy may not matter because the host is decrepit. Your solution?
That's a complicated issue. I think that fundamentally, I think in children, I think the biology of cells, after birth and early life, in my judgment, is very different than at later stages. And as you know very well, at least there seems to be increasing evidence that in MDS, the accumulation of mutations that are involved is age-related. And it depends on, some people get at 50, some people get at 70 and all. So I think coupling children treatment options with adults, I think in my judgment is too naive and simplistic, and we may have to really go back and take a hard look at what the responses are, the so-called same phenotypic disease in child as opposed to in adult. Yeah.
Next question. You have great knowledge and experience in the field now. If you were given limitless resources to plan a cure for cancer, what would you like to do?
I personally, I don't think money solves problems. Okay, good ideas solves problems. So I would not take a lot of money to try to think something I don't strongly believe is worth doing and really well thought out and really thought through exactly what we're going to achieve as a result of this investment of resources into your project. So I really, a strong believer in the fact that you need smart people who are very critical, thinking through critically, and throwing money at a problem ain't going to solve it. I think it proved by war on cancer by Nixon, who started the war in 1970s, and from what you told me hasn't much changed. So I think money is not the solution, good ideas are the solution. Yeah.
And last question. Do you think that offering patients with advanced cancers, non-curable cancers, palliative but very toxic treatments is a service or a disservice in the current therapeutic landscape?
Again, from my perspective, if I have to face the decision personally on my own, I would rather go to palliative care rather than taking strong experimental drugs that are not, in my judgment, are not established, relieve the pain and suffering of the thing. That's again a biased view, but I really think we need to be very careful about it, about how we execute these kinds of studies. And I think it'd be very important to clearly articulate to the patient what we are trying to do to them and explain the risks and benefits. And what we don't know, we should be very clear to them that we don't know these things, but we think it might. I see a lot of false promises being made in all sorts of diseases, not only cancer, but other diseases. I study even sickle cell disease and all. So I think we have to be very careful to explain to the patient clearly what the limitations of what we are trying to do and get their consent before we do anything more than that. So.
Thank you very much, Mohan. Those were very thoughtful and humane answers.
Thank you.
Appreciate your time.
Thank you.